All right, well, good afternoon, everyone. It's really good to see you, and thanks for joining early. For those that came a few minutes ago, it's really nice to meet you, and I'm looking forward to our session today. My name is Erin. I'm a palliative care nurse originally from Canada, and I am based in Nairobi, Kenya, and have been part of the team that's organizing this Project ECHO. And this is a partnership between PallCHASE, the Africa Palliative Care Association, and really focusing on improving access to training for healthcare workers that are currently working in East Africa in humanitarian settings. And we are a community of practice. So we're a group of providers and experts that are working together. We meet once a month for these trainings. We have a variety of speakers that talk on topics, and then we usually have our local teams present a case. So I see that Yoanis is on the call with us. Really good to see you, Yoanis. You finally connected. Welcome, Karibu. Yoanis will be presenting a case from South Sudan that the MSF team has been seeing in their hospital. So please, great to see you. Please rename yourself on your Zoom chat if your name isn't already who you are, but it looks like everyone has already done that, so that's great. And then if you want to put in the chat where you're working, we got to do a few introductions before we started the call. But if you want to put your name, where you're working, and what you do at your clinic in the chat, then the rest of the participants can also see that. Just to remind.
Okay, good.
Thank you, Yoanis.
Yeah.
Great to see you. So for the session today, we'll start with the teaching topic, and then we'll do our case presentation. So just a reminder for everyone that's on the call, myself and Sarah will be watching the chat. If anyone has any questions, she'll let me know. Sarah is also a palliative care nurse that's based in Kenya and is one of our faculty members. So she'll also be supporting the group today. All right, so actually today I will be speaking. Today the topic for the session will be on wound care. So we will do the first 20 to 25 minutes on the teaching about wound care, and then we will shift to the case presentation. So I'll just share my screen. Okay, so today we're going to be talking about the humanitarian response for wound management and palliative care. So we know that many of our patients that have palliative care needs sometimes also have wounds. And today I want to talk about some basic wound management and things that you can do in your setting, even when you have limited resources. And we know in many of our settings, we don't often have access to very high quality wound care supplies. So we'll be talking about that a little bit, and also I'm curious to hear what you have access to in your setting, and we'll talk a little bit more about that. And again, my name is Erin. I'm a palliative care nurse and am one of the executive committee members at PallCHASE, which is a global network that looks at ways to improve access to palliative care in humanitarian situations. So the content that I have been using, I want to give credit to Two Worlds Cancer Collaboration as well as PallCHASE. And again, if you want to use some of the content in the future, please do also give credit by sharing this slide. The content and the training that we do is in accordance with the APCA Palliative Care curriculum. And this is some more information on the course that they have. So if you want, I can also share this link afterwards. The Africa Palliative Care Association is a regional association, also mandated to increase access to palliative care across Africa. So today we're going to be talking about wound management, especially in relation to advanced cancer. So you may hear me talking about malignant wounds. So oftentimes people with advanced cancer have wounds, and sometimes they are wounds that don't heal. So we'll be talking about that a little bit. We'll talk about the treatment of what are our underlying problems, as well as the comorbid conditions. So sometimes our patients have multiple issues that are causing sometimes delay in healing of their wounds. We'll talk about local wound management, some symptom control, and then we'll end with patient and caregiver experience, which is really important when we think about wound care. Okay, so when we think about wound care, you may think of this. So this is a patient with advanced breast cancer. When you think about wound management, oftentimes we are trying to figure out ways to support patients who have malignant wounds. So these are wounds that result from cancerous cells that infiltrate the skin. And oftentimes it leads to tissue death. So the supporting blood and lymph systems often cause a loss in the blood flow to the area because of the cancerous cells, and then the tissues end up dying. What results also is a lesion, or like a wound, which is what we're talking about. And this may be a result of the primary cancer, or it could also be from a metastasis to the skin, from the local tumor or from a tumor in a distant area. So there's a variety of causes of why our patients get wounds when they have advanced cancer. And we know, especially in places where access to treatment, basic treatment for cancer is limited, we often see patients coming to us when their wounds are very bad. So the wounds that we see in our settings can take the form of a cavity, so like a space on the skin that's very open. It could also be an area on the surface of the skin or on the skin nodules, or it could also be a nodular growth extending from the skin. So it can be a cavity, it can be an open area on the surface, and then it can also extend. Malignant wounds often present to us in clinics or in the hospital or wherever you're treating your patients. Maybe it's in home care with odor. So usually it's foul odor with exudate, so lots of fluid and lots of discharge, sometimes with bleeding. So patients can have uncontrolled bleeding from the area. Pruritus, which means itchiness. Often pain as well, and all of these we know can interfere with their quality of life. And an interesting statistic here is that malignant wounds occur in 5 to 10% of patients with metastatic disease, most often in the last 6 months of their life. So these types of wounds happen in our patients where they have advanced or disease that has spread, and can happen at the end of their life, or the last 6 months of their life. So here's a few examples. I'm sure you're very familiar with what serious fungating wounds look like. Again, I know we have a variety of people on the call with us today. Some of you are nurses, some are not. These are just a few examples of what a fungating wound looks like. And it is important for us to look at them. Of course, it's challenging and it can be kind of off-putting to see these wounds. It is really important that we show compassion to our patients because of the impact that these wounds have on our patients. It's really important that we also find good ways to support and provide good care to our patients in these kinds of situations. So as a provider, here, of course, we're not always in our full PPE, but sometimes you will be. So sometimes when you are doing wound care, you do need to take that into consideration. But actually, it's really important for our patients, when we think of what to do first, is that we need to clinically assess them. We need to document and then evaluate the wound care. So when we do this type of care, we know that it's a bit complicated with our palliative patients. And sometimes there's not a lot of evidence to show us how to do this type of assessment, how to do the documentation, and how to evaluate. Yet it is important that we as providers do our best to assess the wounds, again, to document, so monitoring the size of it, how much discharge is coming out of the wound, and then also evaluating our care plan. The three main principles I want to talk about today, and this is where we will go with the rest of the session, is the first one is the treatment. So we always need to think of how can we treat the underlying problem or any other condition that may have caused the wound or may have delayed the healing of the wound. We'll then look at some suggestions for wound management, and then we'll look at the symptom control. So the first one is understanding what is the underlying problem. So any disease-modifying treatment that can be used to make the day-to-day management of the wound easier and improve the quality of life must be done. So this, for example, can be like antibiotics. If it looks like a wound is infected, we do need to treat the wound. If a patient has cancer and they do have access to cancer-modifying treatments, and that's the recommended plan of care for the patient, then we need to recommend that, and we need to advise on that. When we think of treatment, we need to think of treatments, and we need to select treatments that provide minimum side effects and maximum benefit. And this is always pretty standard when we think of our palliative care patients. So patients with serious illness or advanced illness, we do really need to think of the side effects that the treatment may cause, and then also weigh out the benefit for the treatment that we're recommending. So these treatments for sure can involve surgery, of course, often involve chemotherapy and radiotherapy. And we know that this is important when our patients, we know in some situations where we're working, patients don't have access to all of these treatments. When they do, we need to advise that they strive to access that. Something to understand and to remember is that when our patients have multiple conditions or health issues such as COPD, asthma, even issues with their pulmonary system, if they have diabetes or even heart disease, we know that those patients, along with their cancer diagnosis, can have impaired wound healing. So it means that when our patients have a variety of other health issues, it may not only be the cancer that's delaying their wound healing or making it difficult for their wounds to heal. So this is something that's important for us to take into consideration when we think of what are our recommendations and how are we going to go forward with a wound care plan. Okay, so first of all, when we talk about wound care, we need to first establish, is it possible for the wound to heal? Or are we doing palliation for the wound? So that's the first thing to think of. So if the goal for the wound is healing, we need to make sure that the wound bed is free of bacteria and any harmful enzymes that could delay healing. So this often impacts the type of treatment that we would recommend and how kind of intensive treatment we would recommend if we are aiming for a healing wound and if the goal is for healing. If the goal is more palliation for the wound, we need to carefully debride any dead tissue and we need to manage any bacterial overload. Often this is to minimize odor and then decrease the risk of other infections. So the way and the plan of action for these wounds is oftentimes can be different than if we are trying to aim for complete healing of a wound. And it's important that we as a team talk about that and yeah, make a decision together. So when we think of debridement, we think of mechanical debridement. So that's often done using gentle wound irrigation with a solution called normal saline. There's also a different type of debridement, and it's called autolytic. And this is when the body's own enzymes and moisture rehydrate and sometimes soften that hard eschar or slough that is often on the wound. So when we think of this autolytic debridement, sometimes in wound care, people advise to keep wounds open to the air, but actually best practice is to keep the wound bed moist. And this is done through keeping the wounds covered. Moisture is able to help with any debridement of any eschar or slough that's on the wound bed when our wounds are covered. Of course, this can take a long period of time. And again, we need to identify if the wound is a healing wound or if it's more palliative or palliation. So when we think of cleaning a wound, dressings may contribute to the cleanliness of it, and also can limit symptoms associated with malignant wounds. So oftentimes when we have a patient who has a very large malignant wound related to an advanced cancer, it's a non-healing wound, and our patients have wounds that are open. Oftentimes this is before they come to us. Patients can be at risk for developing, obviously, infections, as we had mentioned earlier, as well as maggots can develop. They can have flies that are kind of landing on the wound, and then those maggots develop. And these are all things we want to avoid and prevent from happening. We do need to treat it when it does happen, but when we can keep our wounds clean and covered, then we can often limit those symptoms. So when we're thinking of specific wound care supplies, this is what we usually recommend: large syringes, not with the needle on the end, because obviously we don't want to cut any of our patients. So if you have access to this type of supply, this can really help with that debridement and the flushing of the wound with normal saline. Of course, you want to use gauze, and when our patients have very sensitive skin, we want to wrap our patients' wounds with cling gauze. So on the very far left side, you can see the wrap or the cling, and then there's some 4x4 gauze pieces, which is also a recommendation of what to use. Although I know it's very common practice, we recommend not using solutions such as betadine, Dettol, and Savlon to clean our wounds, because antiseptics actually end up damaging the new cells that are forming. So they're actually too strong. We often use them in surgery. And then for our malignant wounds, we actually advise against it. And this might be something new that you hadn't heard of until today, and that's okay. Sometimes we learn new things. But we really recommend, if you're able to use normal saline, that's the best thing for these wounds that are often difficult to heal and also sometimes unhealing wounds. So antiseptics are not recommended. Why? Because they actually damage the new skin that's healing. We know that these antiseptics kill the bacteria, but they also kill the skin cells. And we want to prioritize, if there is potential for any of those new skin cells to grow, we want them to grow. So we don't worry as much about the bacteria in these wounds as much. So this is why we strongly recommend using normal saline to clean these wounds. So now we'll shift on to symptom control. So we know that for our wounds, symptoms can be systemic, so they can be across the whole body, or it can be localized to where the wound is. So our patients can suffer from pain. Sometimes they can also have irritation around the skin. So the word peri-wound means around the skin of the wound. It can become excoriated or macerated. So that's where there's a breakdown of the skin around the wound. Patients can have pruritus, which is the itchiness. They can have that foul odor. They can have the exudate, which is the drainage or the increased amount of fluid coming from the wounds. And then they can also have that bleeding, or obviously in very serious situations, our patients can have severe bleeding or hemorrhaging. It's also important to know that there may need to be a kind of a plan in place, because we sometimes need to manage more than one symptom at a time. So we're going to take each symptom now and go over it. If you do, again, have any questions, you can put them into the chat. And please do introduce yourself in the chat. We would love to get to know you, who you are, where you're working. And Sarah, my colleague and another faculty member, will monitor the chat as well. Okay, so pain can result from many causes, and it can also be from emotional issues. We know, as you saw previously when I shared some of those pictures, body image is a big deal for our patients. So pain can be caused by a variety of reasons. It's important that we carefully assess and we administer appropriate analgesic. For our wounds, we can administer topical or systemic pain medication. Again, we need to make sure we monitor patients' pain levels and also provide emotional support to these patients. Pain is interesting in wounds because it can be present constantly or only when we change our dressing. So that's why actually for wound care, we often recommend giving our patients their as-needed pain medication 30 minutes before a dressing change, at least 30 minutes. So the patient has access to the medication in their system, so that the symptom is managed. And definitely, if a patient is quite anxious about the dressing change, finding good ways to help them relax. So that could be through music, maybe getting them to be distracted by watching some TV or watching a movie. These are all really important things, and it can be fairly traumatic, these dressing changes. So it's really important that we come up with a plan of what to do, especially related to the pain that our patients experience. So irritation. So we definitely want to find a way to protect and prevent any of the surrounding skin from getting damaged. So the most important way is to control any exudate. So if you have a patient that has a highly exudating wound, so that's a wound that has lots of fluid that often needs to be changed multiple times a day, it is important that we have access to, and we recommend them change it. We don't want our patients to have wounds that are filled with fluid where the dressing is continually sitting on our patient's skin. So this can be done in a variety of ways. It can be looking at your supply cupboard and identifying what kind of supplies you have. Some people in our settings will have access to different types of supplies. You may need to reuse supplies. There will be situations where you have a primary dressing, and then the secondary dressing can be a clean cloth that the patient regularly changes, washes, dries, and then they can use again. There are also some barrier ointments and some skin barriers, often for our patients that have ostomies, where we can protect surrounding skin. So there often are in more urban settings, or if you have patients that are traveling to urban settings and they're able to access some of these more specialized wound care supplies, there are some barrier creams that can be used to really prevent any of that surrounding skin from getting damaged. It is important for our patients to also limit adhesive dressing. So we don't want to use a lot of tape in our patients. So sometimes we can use tube dressings or even the wrap dressing that I mentioned. And then again, if we have to use tape, then if you can use a supply called hydrocolloid, I assume probably it's not available in many of your situations. But if you do have the situation where a patient has really severely damaged skin, it is important that we think of alternatives to that. So oftentimes that's through wrapping and then just taping the wrapped cling directly to the supply, not to the patient's skin. All right, so for pruritus and itchiness, this is often described as a creeping or an intense itchy sensation. It can be really disabling to our patients and often can be difficult to treat. We do need to identify and we need to be aware when our patients are experiencing this side effect. And oftentimes it doesn't really respond well to antihistamines. So sometimes we use tricyclic antidepressants or paroxetine to treat this. And often we want to use some sort of anti-itch cream or lotion. This can be over-the-counter anti-itch cream. It doesn't have to be something that's by prescription. Whatever you can have access to, we usually would recommend. If a patient has access to a TENS machine, we know that sometimes the nerve stimulation can help our patients and can really reduce this symptom. Again, it may not be available in all of our situations, but if there is a center that has access to that, it may be helpful for our patients. The next symptom we're going to talk about is odor. So odor can be very difficult and really have a profound emotional impact on the patient and caregivers, and often can result in social isolation of our patients. So if we have a patient that has a large wound and it smells very foul, what can tend to happen is our patients can not feel welcome in the ward. They can feel very isolated, even if they're at home. They may not have visitors because of how much the wound smells. There are some strategies to control odor. So we often do recommend cleaning the area. So showering, of course, with clean water, using that saline irrigation as much as possible. If there's any necrotic tissue, so if there's any damaged or dead tissue, removing that tissue is really important. That can actually help reduce the odor. We know that necrotic tissue has a really foul odor to it. So using the gentle irrigation and also keeping the wounds covered so that there's a moist environment can help debride that tissue. And then definitely managing the exudate. So changing the wound dressing so that there isn't a dressing that's soaking wet on top of the wound and on the skin. There's other interesting strategies. So oftentimes used in many situations, and I'm sure people on the call today have shared examples like this, of using metronidazole or an antimicrobial on the wound. So what you do is you take a metronidazole tablet and you crush it so that it becomes a powder and you sprinkle it directly onto the wound. If a patient is struggling with really severe odor, of course, they can also take systemic antimicrobials as well to treat that. But we find locally treating a fungating wound or a malodorous wound is also very effective. We do recommend using essential oils or other aromatherapy products in the environment where our patients are. So this can also help minimize the odor and also improve the smell of the area. Sometimes our patients use Vicks vapor rubs under their nostrils to just help, in that menthol smell can help mask any odors, especially during dressing changes. And I know in a variety of environments, the use of charcoal at a patient's bedside can also be helpful. So you just put the charcoal in a bowl and you put it at the patient's bedside or under their bed, and that can also help absorb the smell of the foul odor of the wound. There is some interesting research, and I can share this on our WhatsApp group, from 2014 in Singapore, where they used tea bags to help absorb the smell of malignant malodorous wounds. And the way that this treatment works is you would do your standard primary dressing on the wound. So depending on if you're using any ointments or anything on the wound, if you're using metronidazole tablets, powder, and then you put your primary dressing on. In the secondary dressing, you put a tea bag. So it will be potentially an unused tea bag onto the second dressing, in between the first and the second dressing. And then you cover the dressing. And what happens is that the leaves in the tea bag actually absorb some of the odor. And it's been found to be cost effective and also effective in improving the quality of life of patients, because it really does absorb some of that odor that occurs. In the research that was done in Singapore, they used green tea, but I don't think it matters in particular if it's green tea or black tea. All right, in terms of exudate, when we think of our patients experiencing unexpected drainage on our patient's clothing or on their bed can actually make them feel distressed, and it can also lead to them feeling out of control of their illness. So it's important that we come up with a plan of how often we want to change our patient's dressing. And there are some other highly absorbent wound dressings that are usually recommended, again, not often available in our settings. But if you are working in a setting where you do have access to alternative wound care supplies, using hydrofiber dressings can also be really helpful. If the drainage can't be contained within the dressing, obviously we would recommend that you reach out to a wound ostomy nurse. I know in Kenya, in Nairobi, we do have access to a few of those, so I can also share some of their contact on the WhatsApp group after the call. It is important when our patients have large amounts of drainage that we do assess them for any local or systemic infection as well. All right, our last one is bleeding. So when our patients have spontaneous bleeding or hemorrhaging, this is because oftentimes any tissue that's around the lesion can be very frail, and this can actually cause a lot of bleeding. Prevention is the best approach. So we don't, again, want to use any sort of adherent tape on any of the dressings where the wound is, and being very careful about maintaining the moisture in the wound. If the dressing adheres, so you know when you're changing a dressing and the gauze that you've used, maybe it's a simple basic gauze, sticks to the wound bed, if you take off the dressing, there is a chance that you will cause bleeding because you've taken it off. So we recommend soaking the dressing off with normal saline. And this sometimes is just by pouring some of the normal saline or squirting the normal saline onto the wound and onto the dressing, and waiting a few minutes and then removing the old dressing. If the bleeding does occur after we do the saline soak, we need to make sure we apply pressure. And then for 10 to 15 minutes, you have to apply pressure for quite some time. This is not a standard wound that's bleeding because of the cancer involvement. These wounds often take a long time to stop them from bleeding. In really rare occasions, sometimes our tumors or our wounds can erode major vessels, resulting in a bleed that could actually cause them to die. This is really, really distressing to our patients and our families, of course. And if we were to anticipate this happening, we would want to make sure we had really dark towels or dark colored sheets around for our patients and families to prepare for that in the event that it does occur. Obviously, it's a lot of blood and it's very traumatic for our patients, of course, and their families. So now we'll finish and then we'll go into a time of discussion just related to our patients and our caregivers' experience. When we think about wound care, and especially treating wounds where our patients have advanced cancer, we need to focus our care. So the care that we provide to our patient needs to be at the level of understanding for the patient, and also needs to include their preferences. So sometimes our patients do go home, and we need to help them and prepare them for what wound care management looks like when they're at home. We also need to understand that wound care and having a wound like this can impact their quality of life. So we need to consider assessing that, finding ways to support them, providing some counseling. Of course, also we know that our patients with wounds like this have social and financial concerns, and that's obvious. And if there's ways for us to connect them with NGOs or other facilities that are providing subsidized care, that can be really important for our patients. And then again, of course, as we do with all of our patients and all of the topics that we talk about related to palliative care, really addressing their emotional, their cognitive, and even behavioral and mental health concerns is really important. Wounds, especially for our malignant wounds, can really affect a patient's entire life. So it's important for us as providers to consider that and think about that as well. We do need to make sure that a patient's environment is also conducive. So if a patient has a living situation where it's very uncleanly, that also is something that's going to impact their ability to heal, the healing of their wound. So it's important as we do wound care, we listen to our patients, we talk to them, we understand what's important to them as we give recommendations for wounds. And this is something that we often talk about when we discuss our palliative care interventions. So I just wanted to share a few quotes from an article that was done in 2015. And this was talking about a patient who had a fungating wound. The patient refused post-op radiation therapy and they missed several of their treatments. When they were contacted by phone, the patient said they had excessive breast pain, and that was the reason for their poor follow-up. The patient never ended up returning to their clinic for examination. And I think this is something that happens with many of our patients. They have excessive pain, and then they don't often come back for extra support. Another patient, she subsequently visited, I think this is the same patient, revisited the emergency department 2 months after discharge and had been complaining of a recurrent mass and discharge from the breast, and ended up that it was a large fungating wound from the graft site. And I think with these kinds of situations, when we know our patients are experiencing pain and we don't come up with good plans, our patients can come back to us months later and the wounds can be way, way more advanced, and it can be very challenging for our patients. So I think as we end today, just to remember that as we think about wound care and we think about a variety of the symptoms that we have to address and assess and also come up with a plan to treat, we do need to consider the patient and the family's experience and come up with a holistic plan of how to support them. And I will end there for today. I'm curious to hear if there's any questions or any examples of wound care. And yeah, I'll stop sharing my screen. And thank you. I do have a reference list, so I will share that. This was just a case. We're going to hear the case from the team in South Sudan, so I won't need to show this here, but I can share the list of references as well. So if anyone has any particular questions, I know Lamek has asked a question about maggots. So yeah, so there's a few different concepts related to maggots. What we find in our situations where we have limited resources, where our patients are often in situations maybe where they're in locations where there's more people, they're living in refugee camps where sometimes it's a densely populated area. We actually find that maggots come into the wounds. We're not using it for therapeutic reasons. What happens is a wound is open and then a fly lays eggs in the wound, and then the wound is a moist area, and they end up thriving in that area. It's very difficult for the wound to fully heal in those kinds of situations. I know the alternative is people use maggots sometimes for therapeutic reasons to get rid of dead tissue in wounds, but that's not often what we're dealing with. So yeah, oftentimes we often are dealing with maggots in wounds and we're needing to remove them. Some techniques that work are using turpentine. If you have access to that on a piece of gauze, you hold it kind of above the wound where the maggots are and they're kind of drawn to the smell. And then painstakingly, you need to use a tweezer and remove the maggots. Another way to do it is using fresh meat, like red meat. They're often drawn to the smell of the blood. And again, you kind of hold it over the wound, waiting for the maggots to come up to the smell and then remove them one by one. I'm not sure if anyone else has any experience. I know Annalise has had several patients with maggots in her area, but I don't see her on the call today. Ali, do you guys ever do wound care for patients that have maggots?
Erin does.
Hello.
Good afternoon.
Hi.
And also all my colleagues. Afternoon. It has been a long time.
Yeah, for sure.
Yeah. We had a very long holiday.
Yes. Yes, Eid
We had
Mubarak.
Ramadan and other holidays. Thanks to meet with you again. And outside we don't have a mega tune. Yeah.
Okay.
But we normally have wound dressing care. We normally manage wound dressing.
Yeah.
Yeah. We dress daily and alternate days for some patients with having wound, septic wounds. And we also cover with antibiotics.
Yeah. So usually you try to keep your wounds covered, so maybe the issues of maggots is not as common. Yeah. Okay, another good question. Someone from Duncan. Yeah, we do often use honey in wound treatment. So again, we need to make sure that we're using medical grade honey. I'm not sure, Duncan, which kind of honey is used, but it is really, really effective for wounds to heal for sure. And it allows for that moist wound environment and for the healthy skin to heal. So I know that there's a lot of really good evidence related to medical grade honey. And Sylvester, here the idea of silver nitrate for fungating wounds. So silver is actually also a very effective wound supply that's used in a variety of settings. For fungating wounds, though, it can be a little bit complicated. Sometimes silver is expensive. And for a fungating wound, again, we need to identify, is it possible for the wound to fully heal? Or are we looking more at palliation? Is this a wound that the patient most likely will have for the rest of their life? And we want to focus more on addressing any symptoms, if they have pain and that sort of thing. So therefore, sometimes for using silver, again, depending on how much it costs in your area, I may or may not recommend it. Yeah, I probably wouldn't recommend it if we were anticipating that the patient was closer to the end of their life. They, had less than 6 months to live. We didn't anticipate that the wound was going to heal fully. I probably wouldn't recommend the silver. Sarah, what are your thoughts on that? I know Sarah also has done nursing in a hospice in Canada. Do you guys use silver nitrate on your wounds in Canada?
Oh, hey, Erin. Yeah, sometimes we do use silver nitrate. It can often help stop bleeding.
Hmm.
So if a wound is like bleeding a lot, the silver nitrate can be used. But otherwise, we don't really use it. No. And then I just wanted to clarify for the maggots. I think, yeah, like you said, Erin, there's a big difference between maggots developing in a wound versus using a targeted treatment of maggots, which is sometimes used in very specific types of wounds. I've never used them before in practice or seen them used before in practice, but I know that they can be used, but under very, I think it has to be done under quite careful protocol, and they're not comfortable for patients to have them. So, but yeah, big difference between using them versus finding them in a wound.
Yeah. No, I think the thing with maggots, oftentimes we are dealing with them more of as a nuisance. We're not using them to debride slough and eschar and dead tissue, which is, I think, historically when they've been used in the past, and again under really strict circumstances. But really good questions. I know we have a few nurses on the call today. Does anyone have some extra thoughts on the wound care and what you're doing in your setting that may be helpful for some of our other colleagues on the call today? The thing that's sometimes hard in our settings where we have limited resources, and oftentimes we know our patients with advanced cancer or advanced disease don't get access to treatment, is sometimes it is really hard to know how to manage wounds. And I think to the best of your ability, include others in it. So you may need to refer to your medical director. I think involving other people in coming up with a plan on how to manage a wound is not a bad idea. Involving the nurses, reaching out to our team on the WhatsApp group, getting some other advice, because it can be fairly overwhelming to come up with a wound care plan as an individual provider. So Frederick has a good comment here for their wounds. Anybody who has advanced cancer, they use normal saline, really good. Yeah, IV metronidazole, I assume that's metronidazole, dressings and vinegar, yeah. And do you find, Frederick, that that's an effective kind of routine for your patients? Richard, would you like to go ahead? I see you have your hand raised.
Okay, thank you very much for this session. I would like to just get a clarity regarding to wound care. If someone has a wound and maybe probably it's not advanced cancer, but you've been trying to manage it and there is no progress, especially wounds on the limb. One of the professors used to say, if the wound is really not improving and you've done all you can and you see it's not improving, sometimes it's okay to talk through the patient and maybe do an amputation, especially if it's causing so much discomfort. So someone having no limb or is better than having a smelly wound. The last experience was when someone had a Madura foot and it was so bad. We fought for it for 8 months, but there was no change. the stench, and everyone in the ward would just try to avoid that man and try to run away. So we talked through the patient and we ended up doing an amputation. I would like to know what is your take on that regard, much as the patient improved and healed. Thank you.
Yeah, I think it's a really good comment, Richard, because there are times when the effect that a wound has on a patient is like total, right? We talk about total pain. It's physical, it's emotional, it's psychological. Their self-esteem is very poor. Of course, having surgical intervention such as an amputation is a very serious decision. So I'm sure, I hope, and it sounds like probably you did take a lot of time to consider that. Helping the patient also be part of that decision-making, I think it is really important. I know that at times, I don't think this example that you mentioned, but I know at times when we try to do surgical interventions for patients with advanced cancer, sometimes we give patients false hope that removing an aspect of the wound will, it's really complicated with cancer, especially when you have a wound that's non-healing. So a patient goes to one facility and gets a surgical intervention, and then several months later, it grows back. And that's the part that I would be concerned about. And I think that's not exact example that you gave of this patient and the cause for the wound. But I think, especially for our patients with non-healing wounds, coming up with good treatment plans and talking to the surgical team, if there is, if there is an indication that that would be an effective treatment option, like you're saying, you treated it for 8 months. I think these things all come into consideration. So yeah, thanks for sharing.
I think too that you brought up a really good point, Richard, when you just mentioned that everyone in the ward would avoid this patient or not want to go and visit them for a long time. I think that especially when wounds are really bad looking or they have significant odor associated with them, there can be a lot of shame associated with that wound. And so as healthcare providers, we really have an important role in, really helping to meet the patient's needs however we can. If the goals of the patient are to get rid of the odor, how can we do the best to do that? Or how can we still spend time with the patient when no one else in the community wants to because the wound looks so bad or it smells really bad? It can be a very lonely and isolating experience. So I think that our role can really be to support the patient along that journey, even if the wound won't be able to heal fully because of the spread of disease.
Yeah, thanks so much, Sarah. And I think in these kinds of situations, as many colleagues as you can, to be on the case and to support the patient can be effective to address some of those other concerns. We'll now shift a little bit to our case presentation. And I think I saw Yoanis. Yes, Yoanis, I see that you're there. Would you like me to share my screen, Yoanis?
Yes, you can share your screen, yeah.
Okay.
You can share yours.
Okay, sounds good. So the floor is yours. So we'll now hear from Yoanis and his team. They're going to be presenting a case from South Sudan, and they're currently an MSF team working in a hospital. And thank you. Thanks for the time you've taken to prepare the case, and we're eager to hear. Thanks a lot.
Okay. Yes, hello all the teams. I'm greeting you. And my name is Yoanis Bedpinj. I'm from South Sudan, Malakal. I'm working with MSF Spain in Malakal. Actually, because of time and because also I'm worrying about my network is a little bit poor, so I will just go to the case directly. Okay, so actually, in our sitting we have two hospitals, and then one hospital is adult patients hospital, that is in POC, that is protection side of civilians. And this case is from adult ward now. She's a female of 37 years old, and then she was diagnosed since last year in May as a cancer. And then we can go to the next slide. The other diagnosis is severe anemia also. Yeah. So here is the case details. She is 37 years old, female, present to MSF Hospital in Malakal POC. As I say, it's a protection of civilian site with complaint of severe infection wound in left neck associated with persistent fever and severe headache. As I said, the condition is studied since January 2023 in North Sudan as a very small rash associated with severe headache and fever in left neck, and started growing gradually, which is the rash. The rash started growing gradually, and she went to many hospitals there in Sudan and clinics, but there was no any improvement in condition. And then in April, 1st of April 2023, she went to government hospital in Sudan, which is Medini Hospital, and she was being admitted for surgical management. And in 1st of May 2023, operation was done. And then after 1 month of operations, the second slide, change the slide. Yeah, the wound increased with active bleeding and very offensive smelling. And she was having a follow-up in Sudan, but the only management was dressing and painkiller, which is anesthesia. And then in November 2023, she came to South Sudan and she went to MSF Hospital in Reng, and she was being transfused for blood, 1 unit of blood. And after that, in January 2024, which is this year, she was referred to Juba, and then she was being admitted there, and there was no any management done due to her condition actually. And then next slide. Shift the slide. And then the treatment from date of admission in Malakal POC, she was given tramadol IV, 1 milligram TID, and ibuprofen PO, 400 milligrams, and morphine IV, 10 milligram BID, and folic acid, PO 500 milligram OD, plus plumpinat, PO, 1 such BID. And there was some investigation that was done for her because there was suspicion of TB also that is not mentioned in the diagnosis. She was being investigated for TB. A sputum was collected, and MTB was not deducted. HIV and hepatitis B and hepatitis C was taken, and all result was negative. And CBC and white blood cell was high, and you can see many of results are abnormal in white blood cell and red blood cell. Next slide. And then you have the pain and symptom, including relevant treatment. We have severe neck pain associated with severe headache and fever and weight loss, poor appetite, and dyspnea and vomiting, plus abdomen pain. The management was morphine IV 100 milligram BID plus metoclopramide and paracetamol. And then management was changed from antibiotic actually, because in the beginning she was having an antibiotic, ceftriaxone, and on the 20th of March, antibiotic was being stopped, and then the management remained as just analgesia, which is mentioned in above, morphine and metoclopramide. Second slide. Okay. And then we have psychosocial concern. She's getting good care. Only thing she should do feel that she will not go back again as a normal person as she was living with people, while family and hospital team are doing good care for her. And also there was having a concept that the disease is a danger and it is a killer. Another thing, there were having a concern of disease can be transmitted to other persons. Other slide. There is a family concern. Actually, patient is a twin, and her other twins passed away due to the same condition. Therefore, they are having a concern that the same conditions that was killed the daughter, maybe it's genetic things, and maybe the other daughter can die in the same condition. And it was the same cancer that this second twin is having, is the same cancer that killed the first one. They continue to have concern that they got the disease from her twin daughter, and I think that maybe she get the same cancer from her daughter. You see? So shift the other slide. The communication, patient and family was being informed by COs and MDs and nurse, the palliative nurse in IPD, since the first day of admission about the diagnosis of cancer and medical care that we are going to provide, and about our limitations in management and care. Because actually we have a limitation. Our project is emergency settlement, and even our capacity to diagnose is limited, and even management is limited, and even our ICU is limit also. It's not like when you go to capital or to city, but it's just a secondary medical care. Nurse and other medical doctors and COs are taking news to her daily on providing therapeutic relationship. We have a Hope Center that is providing a psychosocial support, and then this Hope Center is actually a mental health department that's containing counselor and psychiatrists, and they're providing mental health support and management. Other slide. Shift the slide. The spiritual concern, there's a concern that this condition could be caused by magic, especially as they are twins, and according to their local traditional, twins are having a risk of magic. So they went for traditional management treatment, and in the end, the traditional management doesn't work.
Can you guys still hear him?
Yes, are you getting me?
Next.
Oh, yeah, go ahead. Yep. Well, maybe they
I think he's having network barrier. Next,
network.
Erin.
Okay.
Hello?
Yeah, we can hear you now.
Okay. So
You want to go ahead?
yes, go to the last slide.
Can you see the summary?
Yeah, this summary here. Yeah.
Yeah. Shall we do the questions?
Mhm.
Yeah.
So our summary is she's a 37 years old female present or family or patients by herself after informing. Assume yourself in position of family or patients by herself after informing you by medical teams regarding your current condition. What will be your reactions? I think it's clear. Huh? You can put yourself as a patient or family, and medical team has informed you that you have a cancer and your condition have no managements. What will be your reaction? The second question is assume yourself as a medical doctor or COs or nurse treating this patient. What is your management plan and care? The third question is that assume yourself as IPD, as this is your IPD, okay? You have beds are occupied by palliative care cases, which mean your beds are full and you have some patients in emergency rooms that are waiting for admissions and you have no beds in the wards. What will be your management for this condition?
Thank you. Thank you so much for these.
I think those are all. Yeah.
Yeah, thank you so much for those questions.
Yes, go ahead.
Let me put them in the chat. And yeah, interested to hear what people's thoughts and comments are on the case today. So the first question is to assume that you're in the position of the patient or the family, and you've been told of your current condition. What would your response be? So trying to understand how our patients react to these kinds of really difficult situations where the symptoms are very intense and the options for treatment are very limited. And then as the clinical team, how would you manage this case if you have any other recommendations? for the care plan. What do we do in our facilities when we
Erin.
have many palliative cases and we need to think of other ways to care for them? Yeah, Ali, Karibu.
Yeah, Erin, first, before I go to the question, this patient was patient 2 was to several hospitals and several clinics within Sudan country. The last time patient was being referred from the government of hospital, the patient went to Juba hospital and there was no management done. Then in terms of holistic assessment and social history, the patient had a discrimination that people are saying she can transmit this disease. So I think there's also a lot there. We can also discuss on that issue. If we go back to the history of the patient.
Yeah, Yoanis, do you want to share a little bit about like last year? So when the patient had the smaller rash on their neck, is it just in places like Juba,
Yes.
access to any sort of treatment is very limited, or how does that work?
Actually, according to my observations, Sudan having a bigger capacity than South Sudan
Okay.
in terms of management and diagnosis. Yes, and I think because she's coming from Sudan, actually those in Sudan, they have already finalized the case, the diagnosis, and then maybe one of the medical doctors who did the operation, he was not aware actually that the case is cancer, but after 1 month, maybe that was the time that they rely, because after the opening of the wound start growing
Yeah.
to get much bigger than the previous. So I think that was the time that they get the real diagnosis that the case is a cancer, and was not just a rash. Because in the beginning they were thinking that it's just a rash, and maybe they can just open it like this and will get healing within some days. But unfortunately, they didn't manage to find that in the beginning.
Mhm.
They open it and they grow, and in the end, they lost control of it. And as you know, Sudan is already having a crisis, so they jump back to South Sudan, and then South Sudan having a limit more than North Sudan.
Yeah.
Yeah.
Do you have any contact with the surgeon at all anymore, or not really?
No, we don't have any contact with them now, because actually they were a government hospital,
Yeah.
and then we are an organization, so we cannot have a contact with them.
Yeah. Sarah, our other faculty, was just saying that if they were the patient, they would feel really, really sad and scared about the situation. She might be worried about her family and friends, or how they might respond. Yeah, I think finding ways to support the psychosocial aspect of this patient will be just as important as the physical, especially with the history of the sister dying. There must be grief, overwhelming grief already that she's experienced. So I think really focusing on the emotional, the spiritual care. It sounds really helpful that the Hope Center, the mental health center, is there to provide support. I would say that those visits and accessing that resource probably is just as important as her morphine. Obviously, the morphine, I know you're just giving it twice a day. Is there a chance you could increase her morphine dose? Or is it a long-acting morphine? You initially had said that she was on 10 milligrams IV morphine BID. Is she still on IV, or is she able to switch to oral morphine?
Now we shift it to oral. We shift to oral.
Okay,
Once we discharge this patient, we shift to oral.
oh, she's
Yeah.
discharged. Okay. And are you
Yeah.
are you doing wound care on her, or is the wound open? Does she cover
Is
it?
the wound is open, but we do cover. Yeah, we cover. We do cover.
Okay.
Yeah, we do cover.
How is her appetite? Like, is she able to do any activities at home? Is she able to cook? Is she able to visit with her family?
She's not able to do. She's not able to do anything. She's not able to work, and she's not able to do anything because even she's very weak. At the same time,
So do you think her family knows that she's also dying?
they know because the medical team during the round they do inform the family,
Yeah,
and even the mental health department they do inform the family, but in separate way, not with the family together, not with the patient together.
yeah.
Yeah.
And did she seem to have any final wishes? Does she have children?
Yeah, actually in the beginning, but now no.
Her children died.
Yeah. The beginning she was having.
And is she have a husband? Is she married?
She's married and then she have 3 children. All of them they are old. They are above 18 years. 3 of them.
Are they alive?
They're above 18 years. The last one, yeah, they're alive, yeah. And even the husband is still in Sudan also. Husband is still in North Sudan country.
Is she the only one that's here from the family then?
She is the only one, and the rest of the family that are still in Ring, which is north of Upper Nile, the north of Malakal,
Yeah.
border with North Sudan. Yeah.
So do you anticipate that she may die in the next few weeks? Like, does her family know that she's very, very sick?
The family knows, and even sometimes they do call those who are in Ring, they do call by phone, and they get information from the doctors who are doing round.
Yeah.
Sometime, yeah, because there is some people who do come from North Sudan, and they do call to the caretaker who is living with a patient, and they do ask that they want to talk with the doctor.
Yeah.
And we do talk to them, and we tell them the same thing that we tell to the caretaker.
Yeah.
Yeah.
Well, it sounds like you guys are, you've thought of a lot of things. I would say continue. Are you doing home visits right now?
Yeah, we do home visit according to the condition of the patient. If the patient is not able to come, we do. Yeah, but if it is able, we prepare for the family to bring it.
Yeah.
Yeah, we prepare to the family to bring it.
Yeah, I think right now, I think the most important things to do are to keep her comfortable. So continuing maybe every week or every few days, assessing her pain, if she needs more pain medication. Making sure she has, the wound care, I would say, using clean cloths. Obviously, we don't want to make the treatment any more expensive than it needs to be. So clean cloth to cover it. So there's not any irritation. And then mouth care and feeding as she's able to, not to force feed her, but yeah. Is she religious? Is there a church or a Muslim,
Yes,
a mosque that's able to support her?
she's Christian. She's Christian.
Okay.
She's Christian. Yeah.
Is there a community that's able to support her even though she's not near her home?
Come again.
Is there a church that's able to visit
Can you
her?
repeat?
A church or the elder or the pastor of a church to visit her?
No. No, never happened. No.
Okay. I mean,
No.
during these last moments of someone's life, these kinds of things are important. So maybe the next time you're talking to the caregiver, Potentially, maybe she wants to spend some time in prayer with someone. Maybe that would be something that would also provide her some relief from her suffering.
Yeah. Actually, we do give her the follow-up every 1 week.
Okay.
And she do come for dressing the wound care day after day.
Okay.
Yeah, like she didn't come yesterday, then she came today. And she will not come tomorrow, but she will come next tomorrow for the wound care. Yeah.
And what's the plan after she passes away? Will you guys transfer her body to Sudan? Or have you talked about that with the family? Or that just happens after?
I'm not getting you well.
What will happen to her body when she dies? Did she share with you what she wants after she dies? Will they move her body back to her family?
No, she didn't share this information. She didn't share.
Is she still talking?
Yeah.
She's able to talk.
Yeah, she's able to talk. She's able to talk.
So maybe the Hope Center, one of the counselors at the mental health center, maybe can begin to talk to her. Maybe there are certain things that are important to her, especially because her family is separated.
Okay.
And maybe it would be helpful, although it will be very sad to talk about it. Maybe it will give her some relief knowing that she's after she dies, she might be with her family. I don't know. I don't know what's important to her.
Yes, it's important. We can ask this question one day, whether to her direct or to caretaker. Yeah. 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 During the follow-up day.
Yeah. Sarah or Ali, do you guys have any final comments? We're coming to the end of our time.
My comment is very short. And I'm giving this message to Yoanis. He can pass it through that client. He can use spake method for her to do some counseling on. Let them use spake during the next visit when she comes for wound care dressing. Thank you. I don't have more.
Okay, thank you.
Sorry, I don't have any comments or questions, sorry, but thank you very much for that presentation. It was really well done and really informative.
Yeah, a big thank you to the team in South Sudan. I know this is an ongoing case. I think the work that you guys are doing is in a situation that's very difficult. Continuing to witness the amount of suffering this patient is going through is not easy. Many people would walk away from a patient like this. And I think your team is showing a lot of maturity, a lot of respect and empathy, providing compassion for this patient. Even when it feels like your hands are kind of tied, right? There's very limited things you can do, yet being present with her, eventually when she's not able to come to the clinic, doing the home visits. These are all aspects of holistic palliative care. And I'm really proud of you guys. Keep doing it. We're here to support you. Of course, just message us this week. Sarah and I are around. Ali is around if you guys need more support or recommendations, or you just want to talk about what's going on. Sometimes debriefing these kinds of cases is also really important. Just reach out to us, okay?
Thank you. Great. Okay. Okay.
Okay, everyone, thank you, Yoanis. Thank you, team. It's great to see you, and we'll continue with our sessions again in May. So we'll see you then. Thanks, everyone, for joining. Have a good night.
Thank you.